my name is Sherry Haggerty. This is my presentation on RSV or respiratory syncytial virus. What is RSV? RSV is part of the Pneumoviridae virus family. The world knows RSV as a common cold or common respiratory virus that causes mild cold-like symptoms such as runny nose, cough, congestion, sneezing, fever, and wheezing. Just from my experience, I have been in pediatrics for the past 10 years, and it does target, and I'll get more into detail into this later in my presentation, but it does target the child care age group. So anyone from 5 and under get hit hard with it. And adults don't think nothing of it because, again, it just seems like, oh, it's allergies or common cold, when in reality it is RSV. A little bit of history on RSV. So RSV was discovered in 1995, but cool fact, it was not initially discovered as a respiratory illness in humans. It was actually discovered and named after a chimpanzee covert agent that was discovered during a study of 14 chimpanzees who were suffering from a cold-like symptoms. It was then after case studies in injecting the virus into infants that it was discovered that it causes respiratory-like symptoms in adults. Today, it is actually the most severe disease in infancy. RSV can target both adults and children, but more common in infancy. So kind of like I just mentioned that the adults that are getting targeted with it are those that have small children that have come in contact with it or have been diagnosed with RSV, go on to get it. But it's not as severe because, again, it just manifests as a common cold. And then we do see a lot of child care workers, so those that work at schools, daycares, libraries, and things like that. Those adults are also getting it. What causes RSV? Okay. The most frequent cause of RSV is bacterial Streptococcus pneumoniae. Okay, RSV is enveloped RNA virus, and so what happens is that the RNA virus, or the enveloped RNA virus, attaches themselves to the host cells that leads to the membrane fusion and then the disease forming. You can kind of get a visual representation here of how it starts, and we'll get more into detail into that as well. So what happens is RSV virus causes their cells line the respiratory tract, called the syncytial. Okay, these cells are called the syncytial, and so what happens? It starts lining the respiratory tract, and then they start out in the epithelial walls of the nasal, like pharyngeal, where it attaches themselves to the host cells, and then the disease implementation. So then it just spreads down. Okay, so you're breathing it in, kind of like on my visual here. You're breathing it in, it's entering through your nose, through your mouth, okay? And then what's happening is that it's planting itself in the epithelial cells, and then it's migrating down. Cool note is RSV has an incubation period for 3 to 5 days, and so what happens is you can come in contact with it 3 to 5 days prior to you even exhibiting any of the symptoms. So infection with RSV is primarily acquired through close contact with an infected individual or exposure to the direct airborne secretions into the eyes or nose. And so you can be around someone who has it, they can sneeze, the particles in the air, you come in contact with it, and bam, you are infected. As we learn all through class is that hand washing is so crucial. It's as crucial with RSV because what happens if you can come in contact with like an area that the infected person has contaminated, you touch it, you forgot to wash your hands, you rub your eyes, eat, all of this leads to you coming in contact and getting infected. At room temperature, RSV is in the secretions of patients may survive, okay, on countertops for about 3 to 30 hours. I thought that was a really cool fact about it. So back, I'm kind of touching base back again on the course of the disease. So RSV replicates in the respiratory epithelium. Okay, so what that is RSV travels to the bronchioles, the breathing tubes of the lungs, leading to an increase in the mucus secretions. And so that's why whenever it targets our pediatric population, is that their bronchioles are already so small, and so what's happening is they're being blocked by all the secretion, and so that leads to secondary complications such as labored breathing, stridor. We see that a lot, and those patients ultimately lead into hospitalizations, unfortunately. Children are greatly affected as the increase in the mucus secretion causes the airflow blockage, what I just went over. That's whenever you see, again, the retracting, stridor, and croup can occur because of the lack of airflow. Detection and intervention, okay? And so how we detect it is you can do a rapid PCR nasal swab or by a blood draw. So at the hospital settings, you're gonna see that blood draw, but in a clinical setting where I work, we do rapid PCRs and actually have a swab. And so these swabs, they're nasopharyngeal swabs because, again, as I mentioned previously, that the route of the virus always starts up in the nasopharyngeal area where then it embeds. So what we do is we take these little swabs, and I'm going to touch it, of course, but we go up the nasal cavity until we kind of get hit like a little wall. And so that lets me know that I'm deep enough, and I just swivel it around just to get as much secretion as I can. And then I go into my lab, and then we have machines that we put liquids into and are able to detect what kind of virus it is. And so in a clinical setting, you have your basic PCR, like you can test for COVID, flu A, flu B, and RSV. In a hospital setting, you're going to be able to test for a much more in-depth variety, so like adenovirus and things like that. Rhinovirus, all of those are going to be included in this report, whereas just for us, we do just rapid PCRs because that lets me know right now what's going on right now. We're more like a Band-Aid kind of place. So again, detection and intervention. So we want to make sure that we have a confirmed diagnosis. RSV infection require no more than usual supportive care. It sounds like it's not that big of a deal, but what happens is you can go downhill very quickly, and that's when you run into the problems that you're going to need hospitalizations, you're going to need oxygen, and things like that. So just supportive care, breath, comfort, fever control, and just making sure that we're keeping those fluids in. That's going to be your detection and intervention. Excuse me. Babe, can you go back outside, please? For bronchiolitis education, sometimes administering bronchodilators, so like inhalers, nebulizer treatments, corticosteroids, what that's going to do is going to open up the airway to make sure that the airflow is going back in. And then antibiotic usage should be reserved for those showing a bacterial infection in conjunction to it. So like if you start out with RSV, but because of all the secretions, we see in our pediatric population, it backwashes into the ears, causing otitis, which is an ear infection. You can have strep with it as well. Very uncommon. I'm sorry, it's very, it's not as common like you would see it with an ear infection. Sorry. So again, touching base on that population affected, it's going to, fun fact also that I discovered is all people have experienced RSV at some point in their life, common cold in adults, and then those that work around children. Another fact is 172,000 children that were younger than 5 have been reported to be hospitalized annually with RSV. And that is my presentation on RSV.